Hello and welcome everyone to our latest presentation on the pulmonary artery catheter and its relevance in ICU currently. Ever since the paper has been published, that is the PACman, it was published way back in 2005, the use of pulmonary artery catheters has significantly declined. Let's see what was the finding of the study. In this, they showed that the association of PA catheter did not result in better outcome. Rather, it was associated with worse risk of survival. Since the catheter was associated with difficult technique and also other complications like arrhythmia while insertion, the overall use of catheter has significantly declined post the publication of this trial. Let's look more closely into what was the conclusion of this study. So the first thing they said was that this study, along with the previous studies, has shown that the effectiveness of PA catheter in intensive care unit has shown no overall advantage. However, we are finding new, sophisticated and less invasive diagnostic monitoring techniques which are becoming increasingly available. But the most important thing that we missed in this was these non-invasive methods of hemodynamic monitoring have not been formally assessed. This was the statement way back in 2005 and it still remains true even in 2021. The lesser invasive methods of hemodynamic monitoring like PICO, flow track have not been validated for use inside the ICU. Now, the benefit might occur of using a PA catheter by a skilled use of this. Its declining popularity and decreased familiarity among the nursing staff and the medical staff mandates regular training to maintain the required skills. But this has been completely ignored and we have absolutely reduced the use of this catheter. So there is almost negligible training of residents on the use of PA catheters. Now, efficacy studies are needed to ascertain the optimal management protocol and to identify group of patients who could gain from the management of a PA catheter, which would otherwise make the technology redundant. Now, we will try to find out, is there any subgroup where we can still use the PA catheter or it's just a redundant technology. Now, there have been guidelines which have been published for the management of cardiogenic shock and review articles like this. Well, there was a guideline which was published by Intensive Care Medicine in 2014. In this, they recommend that if the patient has a cardiogenic shock, or for that matter, holds true for almost all kind of shock, the first method that should be used is echocardiography. This provides the most robust information and helps us in pinpointing exactly what could be the probable cause of the shock. However, there is a pyramid for this echocardiography skill, especially for ICU. Though right now, currently almost all the doctors who are working in intensive care have this bottom training, that is almost everyone is able to detect a large pericardial effusion, recognize marked RV dilatations, measure the IVC and recognize severely abnormal LV contractility functions. Overall, training also requires to be more intensive and it also takes more time as the pyramid goes up. For example, to find out gross valvular disorders, measuring actual cardiac outputs and ejection fractions, or for that matter doing a full range cardiac evaluation with echocardiography requires a lot of training as well as time, which is not something which everyone is accustomed with. Transthoracic echo does give us very important informations about the cardiac functional status or the cause of shock for that matter, especially the right ventricular function. Here we can see the dilated IVC. Here the IVC is seen clearly dilated and there is a pericardial effusion. So this is showing that there is a very high chance that this patient has a right ventricular failure. Apart from this, we tend to find information regarding the valvular function. Here we can see the left ventricle is dilated, the right ventricle is dilated. The right ventricle is almost the same size of the left ventricle, which means there is a significant right ventricular dilatation, and we also find a tricuspid regurgitation. Apart from this, here we can see the extremely dilated hepatic veins, which shows again a feature of pericardial constraint or right ventricular failure. The second recommendation is, once you have found out what is the actual cause of the probable shock, then we need to measure the cardiac output, especially to evaluate the response of ionotropes. Now, for that matter, we have very limited devices with us. The currently non-invasive devices that are available are not validated in an ICU population. They have only been experimented in the OT setup, especially in normal population. So how do these parameters get affected when a patient gets into actual shock is something which we have not yet evaluated till now, and the utility of these devices is still not established. So this line, that the measurement of cardiac output or stroke volume, exactly how it needs to be done, has not been emphasized and not been clearly told in any of the guidelines. However, if you do find a refractory shock and a right ventricular dysfunction, then it is always wise to put a PA catheter. Now, regarding the use of PA catheter, its use has been declining since 1999, and this is a study which has tracked the usage in US from 1999 to 2013, and they see reduction in the numbers PA catheter usage. Now, its usage has drastically reduced, especially in respiratory failure, followed by in acute myocardial infarction. However, its utility in the cardiac failure still remains, and recently we are seeing a slight upturn in the reducing graph. Now, this was a study which was published from Japan. They looked at the PA catheter and the outcome following heart failure. And in this, they found the use of PA catheter was associated with reduction in all-cause mortality and reduction in cardiac death. Both of the values were statistically significant, showing there is a good effect of PA catheters on outcome in acute heart failures. Now, this is a guideline which was published by European Council on right heart failure, and in this, after the initial assessment of severity and identification of triggering factor, next we need to go for hemodynamic monitoring. Here in hemodynamic monitoring is emphasized that the usage should be done for a PA catheter. Now, looking into cardiogenic shock complicating myocardial infarction, in this review article they show that after the initial stabilization, the hemodynamic instability, if it is persisting, then it is always better to go for a PA catheter, because doing repeated echoes is not something which is practical. Echo, as such, as we have seen, repeated measurements are very difficult to do, and even to do a proper full assessment, it takes a long time. So doing it multiple times a day becomes very tedious and very difficult for the staff. So PA catheter is something which gives us minute to minute information about the right ventricular function, about the cardiac output, which can help us in monitoring the inotropic support that we are giving. This was an editorial on the debate of, is there still a role of Swan-Ganz catheter, which was published in Intensive Care Medicine. Now we'll look as to what the people who told yes for Swan-Ganz catheter had to say. In acute circulatory failure, after the initial assessment, if there is an associated severe ARDS, they do recommend to use a PA catheter. Rebecca, they published that they are still not sure whether Swan-Ganz should be used or not to be used, and they do recommend the same thing, that if the patient has a ARDS and right ventricular impairment, it is better to go for PA catheter. They are also recommending PA catheter even in ARDS without right ventricular impairment. Now, this is an important study which was published. In this, a complete hemodynamic profiling with PA catheter in cardiogenic shock was associated with lower in-hospital mortality. In this, a complete assessment meant that you found the pulmonary artery systolic pressure, a pulmonary artery diastolic pressure, capillary wedge pressure, and the pulmonary artery saturation, and the presence of a right atrial pressure. All these parameters must be in front of the doctor and the nursing staff so that they can titrate their therapy. Only then we get a good outcome with PA catheters. Just putting in a PA catheter is not going to help in improving the outcome. We need to do a complete assessment, and we need to do some intervention and continuously monitor those intervention based on this assessment. In this, you can see this blue graph and the orange bar. Both of these show a slightly higher mortality rate. This blue one is without a PA catheter. This orange one is with a PA catheter but without a complete assessment. So if a complete assessment is removed from a PA catheter, it is obviously not going to do a much change in terms of mortality. However, if a complete assessment, here shown in a gray bar, is done, then there is a significant reduction in the mortality after using PA catheters. So to conclude, do we still have any indication for PA catheter in our ICUs? Well, in case of rapid hemodynamic instability, initially echocardiography is must and should be done to decipher the cause. For this, a lot of expertise is not required, and it is something which can be done quickly and very fast at the bedside. So early echocardiography is very, very important and should be done. However, if there is a persistent hemodynamic instability, you cannot do echo repeatedly, especially a echo requiring complete assessment of all cardiac output, ejection fraction, pressures. It is very difficult to do. And if you are having severe ventricular failure, the assessment of right ventricular function in echo becomes also very difficult. So PA catheter is recommended in case of persistent hemodynamic instability in the ICU, or if the patient has severe right ventricular failure or even severe ARDS, where a right ventricular failure can occur anytime. So in all these cases, we can still use a PA catheter in the ICU. Thank you for your patience, and check our website for further information.